ask lots of questions. This is really one of my favorite things to talk about, and I'm excited to be here all with you. So what we'll do today is I'll give you a little bit of an introduction and an overview of the subject. We'll talk a little bit about sort of what the word bone cancer and bone sarcoma refers to, and then dive into the treatments, especially those that are surgical. I have a little disclaimer here coming up next. Oh gosh, is my internet slow? There we go. So as a surgeon, when I give talks about the surgeries that we do, I do have some photographs in this lecture that are actual pictures from the operating room. They're from real surgeries that we've done. So you'll be looking at the inside of people's bodies. So if that feels a little odd or makes you squeamish, feel free to look away, and we'll get back on track with things like x-rays and non-surgery pictures pretty quickly. So first, let's start out with the basics of what is a tumor. So as I mentioned, my specialty is called orthopedic oncology or musculoskeletal tumor surgery. And that often gives people a lot of anxiety because I take care of a lot of patients with tumors who don't have cancer. So the basic word tumor simply means an abnormal growth. It can represent things that are cancerous, but the vast majority of tumors that people have are actually non-cancerous. So I take care of people with abnormal growths that are both cancerous and non-cancerous, and take care of patients from the whole age spectrum. So from kids all the way through adulthood and even our oldest geriatric patients. When we think about cancers in general, I want to share with you some statistics to kind of give you a point of perspective for these bone cancers or the bone sarcomas that we'll spend most of the time talking about today. Lung cancer is among the most common cancers that we see in the United States. And you can see here, based on some data from only about a year and a half ago, there are over 230,000 cases of lung cancer that are diagnosed every single year. This represents about 12% of the new cancers and almost 20%, unfortunately, of the cancer deaths. Cancers like breast cancer and prostate cancer are almost as equally common. Bone sarcomas, though, and things we commonly refer to as bone cancers, are much more rare. As you can see in the United States, back in 2023, we only saw about 3,900 of those. So only 0.2% of the new cancers. So pretty rare diseases. And that's what we're going to talk about today. Interestingly, the vast majority of patients who have these types of cancers are children and young adults, and we'll talk a little bit more about some of the special considerations that we take into account for all of this. One of the really great things is that over time, as you've learned from just the media in general and news that's coming out about our cancer treatments, is that we have been able to achieve on the surgical side really better and more functional outcomes while we treat these cancers and rebuild them from the perspective of durability and longevity. And it's become a really exciting opportunity for those of us who get to provide this care. So with that, I'm going to dive in a little bit and talk about how we make these diagnoses and how we discover that patients have these conditions. The first thing that's really important to us is really understanding the age of the patient. We know that cancer can affect patients from the very young to the very old, but when I think about orthopedic tumors and orthopedic cancers, understanding if someone is young or old helps me put things into a different category. We commonly see tumors in bones that have spread from other cancer sites, like lung cancer or breast cancer or prostate cancer. But those things typically happen in patients who are over 40 years old. Bone sarcomas that we're going to spend time talking about today happen in people and patients who are actually much younger. So often they're 8, 10, 12, 14, 16 years old. So age right away is a really important thing for us to understand. We then like to know if people have family histories. Some of the cancers that fall into this category can be related to hereditary conditions or some genetic alterations. And often when we see children and young adults with these tumors, they show up to the office with lots and lots of pain, swelling. Sometimes there's a mass that's starting to grow. They're kids who have pain all through the night that they describe as deep and really aching, but often no other prior history of cancer. As an orthopedic surgeon, I love looking at imaging. I love looking at x-rays and CAT scans and MRIs, and these are the things that help us start to figure out what's going on. If you've ever been to an orthopedic surgeon's office, you've probably had an x-ray. It's a tool that is really readily available to us. And it's something that can give me a really quick answer about what's going on with a patient. These are two x-rays of an adult patient's right hip, and you can see in the image on the left of your screen, this sort of clear area here in this lower part. And you can see it almost has a darker wall around it. And this gives me a very reassuring look. In contrast, the picture on the right, you're seeing that bone is starting to disappear. There might even be, there is most definitely, right, a crack that you might be able to see through this. And this tells me that the patient has something that's aggressive or really rapidly growing. X-rays can always also be helpful to help me figure out if something is made of bone or if it's a growth in the soft tissue. So this was a patient who came to see me with a firm lump on the side of their hip. Here's the hip joint itself, and then you see this sort of cloudy collection out to the side. And this is actually a soft tissue collection of calcium, not a tumor at all. And I was able to glean lots and lots of information from just this x-ray alone. As simple as a test as that seems, they're tremendously useful to us. MRI is sort of the next tool in my toolbox, and is much more sensitive and sometimes shows me sites of tumors that I might not be able to see on x-ray. So in this picture right here of an MRI, it's of a patient's pelvis. You can see there are two thigh bones here on the left and right, and the pelvis is up above. And you can see this arrow pointing to a light spot in the bone, and that's a tumor that's growing in this person's thigh bone. But what the MRI also was able to show me was a tumor on the opposite side of the pelvis that we weren't able to see with x-ray. So it's a really wonderful tool to help us see things that we can't with normal x-ray. MRI is also a wonderful test to help me look at things like nerves and blood vessels and the spinal cord. This was a patient who had a tumor that was pressing right on the spinal cord, and you can see where this is bulging in, pressing on this. And it's a beautiful way to understand exactly what's going on with this patient to help us make a plan for how to take care of them the best. CAT scan is also a really helpful tool for us, especially in bones that aren't flat or straight. If you look at your own body and your own skeleton, we have lots of bones in our body that are flat and straight and are very easy to take two-dimensional pictures of, which is what an x-ray is. Your arm bones, your thigh bones, your leg bones. But your pelvis bone is really shaped like a bowl. So it's a rounded, curved structure that makes it a little challenging to get a good picture of with a plain old x-ray. And a CAT scan is an excellent tool for that. And so in this picture here, you see a CAT scan image of a patient lying on their back. Their belly is towards the top of the screen here. And we can see that there's a couple of holes in their pelvis, one here, and one on the other side, none of which we were able to see with an x-ray. And then the last set of tools that are in my toolkit are PET scans and bone scans. And these are really fantastic opportunities for me to look at someone's skeleton and their body really from the top of their head to the tips of their toe. And this is an example of a bone scan. And you can see that all these dark spots on this view from the back and here on this view from the front represent tumors in this person's skeleton. So we have lots of opportunities and lots of things to be able to help us narrow in on what's going on, really see where things are happening in someone's body and get a good sense of what's happening. The next really important step is making the diagnosis. So the x-ray and CAT scan and MRI images are wonderfully helpful for us, but they don't always give us a direct answer. And so the best way for us to get a very accurate answer of what this tumor is and understand how it acts is to get a biopsy. Biopsies can be done a couple of different ways. We try to do them as minimally invasively as possible when that is an option for us, and that gets done with something called a needle biopsy. Other times we have to do a small surgery where we actually go in and take a little piece of tissue and then sew that up and send it off to the lab to be able to know exactly what we're dealing with. And when we talk about bone sarcomas, the three most common that I take care of most are these that you see in front of you. So one called a Ewing sarcoma, which is pretty rare. Another that's called an osteosarcoma. And for anyone that's had a dog, you might have heard of this before. Osteosarcomas are actually also quite common in dogs. And then there's a third one called a chondrosarcoma. The thing they all have in common, and the thing we're going to spend the rest of our time talking about this afternoon, is surgery. And so when we do surgery for these patients, especially when they have a tumor that can be treated and cured, we want to think about removing and reconstructing it. One of the most exciting things that has really happened over the last 40, 50 years is that the treatments for these bone tumors has evolved. In the old days, back in the 60s and 70s, before we had treatments like chemotherapies, a lot of times the only surgical option for patients with these types of tumor was an amputation, which you can imagine has a lot of impact on somebody's life, somebody's function, and their ability to get around. Over the years, thanks to the chemotherapies and other treatments that have come out and been discovered and have been quite effective, we have lots of options to do what we call limb sparing surgery. So that means removing the tumor, reconstructing it, but allowing someone to keep their limb, right? That even if you have a tumor in your arm bone, we can remove that, reconstruct it, and you still have your hand, and we can avoid an amputation. And now in 2025, we're able to do limb sparing surgery in probably about 90 to 95% of patients, which is really wonderful. And so I'm going to dive into some examples of all of this. So sorry, I threw a surgery picture up here without giving you a warning, but we'll talk about some of the cool things that we can do once we remove the tumor. My number one goal when I am doing surgery is to remove the tumor and remove it in its entirety. That gives our patients the best chance of being cured of their tumor if this is the only site that the cancer has been found in, and it gives us gives the patient the lowest chance of it ever coming back in that same site. And then we can reconstruct it with a number of different techniques, which we'll talk about now. The most common that we use is a joint replacement. You've probably known friends, families, maybe you yourself has had a hip or a knee replacement or even a shoulder replacement. We know those are really common surgeries that happen and that we do for arthritis. We have versions of joint replacements that we can use to replace really large portions of the bone. So this was a patient who had a chondrosarcoma. It was one of those three that I mentioned a few minutes ago, and it's a cancerous tumor of cartilage. And he had a tumor in the upper part of his arm here. And if you have real good eyes, you can see that maybe there's like a clear area here in the bone. It's probably even easier to see the break that happened through the tumor. So the surgery that we had planned for this, in order to remove the tumor completely, was to take out really almost half of this patient's arm bone. And I'm going to show you some surgery pictures here of what that looks like. So we go in and we open everything up, and here's the arm bone that we're slowly removing from the patient's shoulder. The shoulder socket is deep down here. You can see really beautifully all the nerves and blood vessels that eventually travel from the arm down to the patient's hand. And then once we take that bone out, this is what we're left with, a big hole. The rest of the arm bone is down here. Again, here's the shoulder socket. And now we get to reconstruct this. And we reconstruct that with a big metal arm bone. And that goes into a partial shoulder replacement up at the top. And this is what the x-ray looks like. The patient after this surgery is in a sling for a period of time to allow them to recover. Their elbow and hand worked perfectly well. They were able to go back to doing desk and computer work and ultimately did really well from their cancer, which is always our main goal. We do this similarly in other parts of the body. So this was a patient who had a tumor in the upper part of the thigh bone. So if you take a look here, this patient had an osteosarcoma. You can see this, the ball here in the socket of the hip joint, and then the tumor is here in the upper part of the thigh bone. On the right side here, you can see an MRI of that, and you see some number markings here, and those were our measurements that we were taking for where to plan our surgery. We went in, we completely removed the piece of the bone with the tumor and some of the tissue that we did the biopsy through. And then we reconstructed that with a partial hip replacement that you can see here that really also replaces part of the thigh bone. So a really cool opportunity to let people get back to function once they've recovered completely from their surgery and from their cancer treatments. This case is this. We'll show you a surgery that's actually one of my favorites to do. This was a patient who was 17 years old who came in to see us because he had knee pain and swelling. He'd had a collision with his friend that sort of brought this to the forefront, but his pain and symptoms never went away. He went to his pediatrician who got an X-ray and which showed this tumor here, right inside of the bone. You can see this big clear area, and that's the tumor eating away the calcium of the bone. It's much easier to see on the MRI right here. And on the left, you can see an MRI of the original tumor. I'm outlining it here for you inside of this yellow circle. And then he got chemotherapy for this Ewing sarcoma, and you can see that it looks much smaller and much more contained, which is a really exciting thing for us to see after someone's been treated. Now the job was to come and do surgery to remove this, because even with chemotherapy, we still need to do surgery to remove this tumor completely to cure this young patient of their cancer. And so here are some more surgery pictures coming. So we go in and we open up the knee and then start to remove the tibia bone, that upper leg bone. And now you can see when that bone is removed, there's a big hole to reconstruct. One of the things that I enjoy is really doing these reconstructions. And when we do reconstructions in this area, we also have to reconnect the tendon to the kneecap, because that's what mechanically helps you straighten out your knee. So right here at the top of this picture, you can see where that tendon was cut, and we're going to have to reattach everything, and I'm going to show you that right now. And so here in this picture, oops, went one too far. You can see the sort of mega giant knee replacement that's here in place that replaces also the bone. And then we bring the kneecap, also known as the patella, down onto the replacement, tie it, and then wrap it with a portion of the calf muscle. And what that does is it allows all of those tissues to heal together, so the chain from the new metal bone to the kneecap to the muscles on the front of the thigh is now reconnected and functions to let that patient be able to straighten their knee, even though we've had to detach and reconstruct everything. And this is what it looks like on X-ray. It's a really fun case to do, and patients do really well. This patient was cured of their cancer and went on to live a nice long life, which is really wonderful. Another way we reconstruct things from time to time is by using donor or cadaver bone. One of the places I think this is the most useful is in tumors that are kind of between the joints of a bone. So in the middle of an arm bone or in the middle of a leg bone. This was a patient who was 16 years old, who on this X-ray, if anyone is astute enough, might say looks pretty normal. And I would contend and say the same thing. But on an MRI that he got for a little tiny abnormality, you can see this is all this bright white is abnormal. And this bubble that's here is a tumor. This was an osteosarcoma that this young patient had. In kids, when we think about doing big reconstructions, we want to preserve their natural joints. We hope that they are going to live very, very long lives for many, many decades. And a 17-year-old living with his own knee is much better than them living with a knee replacement, which we usually like to reserve for people who are older and less active, because they are mechanical parts and can wear out and need to be replaced. So we want to do reconstructions that are nice and durable and will hopefully last the person the rest of their life. In this case, we thought we could get really fancy, and I'm looking at this, and I'm sorry my green markers are off, but you can see some of the dotted lines. We thought that we could, using computer navigation, do a really sort of fancy dissection and carve around the tumor, leaving his knee his knee joint intact, even leaving part of the tibia intact, and then putting the bone back together. And that's exactly what we had planned. And so here's a picture from surgery. That's me with the tool in my hand. And if you notice where my eyes are pointing, they're not looking at the patient's leg. They are looking at a computer screen to which this drill and this saw is connected, and it's helping guide exactly where I want to talk. I'm sorry, where I want to cut. And so what we ended up with, this is the cut that we made. So his knee is up here. You can see sort of the outline of his kneecap. Here's the upper part of the shin bone. We left a little bit of his bone in the back, just as we had planned, and bone down here. And this is what we removed. And you can see here's that little bubble that you saw on the MRI. This was his tumor that we removed completely, and then rebuilt everything by cutting a corresponding piece of donor bone and putting it into that gap and putting everything together with a plate and screw. Once this healed, about 3 months later, he went on to playing basketball with his friends, finished high school. I've actually seen him recently. He is healthy and well and living a wonderful life, which is a really great outcome for us. Sometimes, especially in bones or joints that don't move a lot, we can do something called a fusion. And what a fusion means is that we take two pieces of bone and we fix them together so that they don't move anymore. A long time ago, far more than 50 years ago, occasionally we would fuse joints that were intended to move, knees, hips, shoulders, for really bad arthritis when we didn't have great joint replacement options. We have better treatments now, so we don't do this very often. However, there are some parts of the body, like the spine and around the pelvis, where this can be really useful to us. So this is a case of a patient with a very large chondrosarcoma of the pelvis. Here, all the white that you see is abnormal, and that is the cancerous tumor. And you can see another image of that here, right? A very big tumor around the pelvis. And with this case, this is a case of a colleague of mine. They planned to do a really complicated surgery, taking out part of the sacrum or the tailbone and then part of the pelvis bone. And these are some computer models showing where they planned to do all the resections or the removal cuts of the pelvis. You can see here part of the tumor on this computer model, and then what was going to be left over, which is a big hole. Nothing is connected anymore. And so what happened was they reconstructed everything with very complicated rods and screws. We commonly see these in spine surgery. And then we added they added actually some donor bone into that to even create some struts. So a really complicated both surgery and reconstruction for a very difficult problem. And the patient ultimately went on to do pretty well for the years that they lived with actually a very complicated cancer case. But sometimes we don't have to rebuild anything at all. And this is always really amazing when I teach people about this, especially our residents who think, every bone we have to rebuild, and that's not actually the case. A really good example is the fibula bone. So this was a young boy. He was about 11 years old with this osteosarcoma of the fibula in your leg. Below your knee, you have two bones, your tibia, which is the big bone, and the fibula, which is the very small bone. You can actually walk and play and run and jump and do lots of activities without a fibula whatsoever. So this young boy had chemotherapy. You can see his tumor here really sticking outside of that bone a lot. The chemotherapy shrunk it really nicely for us, which is what we wanted to do. We went into surgery picture coming. And you can see here, this is the fibula bone with all the important nerves and blood vessels around it that we are very careful to protect and take good care of during the surgery. And then after, this was him. We didn't have to do anything for him at all. You can see this little, looks like a dart up here. We call that an anchor, and we use that to reattach a ligament that we had disconnected. But once he had healed from surgery and finished his chemotherapy, he went back to being an active 11-year-old and doing all the things that you would hope and expect for someone at that age. So a really fascinating outcome for him. And then sometimes we even do this in the pelvis. This is a case of a young boy who had a tumor in the pelvis. And again, you can see all the bright white. That is the cancerous tumor that's there. This bright white is just what's filling his bladder, so totally normal. We plan to remove all of this, but because we were removing so much of the pelvis, we elected to just kind of let the hip float where it was. So we did a really big surgery. I'll show you a couple little pictures of that. And here's what it looks like. The ball of the hip. You can see the cut part of the pelvis, and we put everything back together. And this is what his x-rays look like. And if you look at that, you might say, oh gosh, that looks sort of weird. If you look at the ball and socket of on this side of the image, that is what normal looks like, and this does not look normal at all. That ball is floating way high. But the really amazing thing is that patients with this type of surgery, and where we've reconstructed kind of the abdomen and some of the muscles around the hip, can actually do really well. And this was uh, that's him walking without any cane or crutches or shoe lift. I've had other patients on whom I've done a similar surgery who have gone back to playing sports with their friends and have had a really wonderful outcome. So we do really great things. We try to do really great things for our patients whenever possible. And then finally, amputation is something that we consider from time to time. I shared before that in the vast majority of cases, we're able to do limb sparing reconstructions and rebuild the holes that we make by removing tumors. But in some situations, that's just not possible. Unfortunately, there are some places where we don't have great replacements. So this was a young girl who had an osteosarcoma of the lower leg, and you can see kind of this little fluffy stuff outside of the bone. I'll show you her MRI. This is the normal sort of size of the bone, and all around here is unfortunately the cancer that she had developed. Um, in this part of the body, we don't have a good way to rebuild the lower part of the leg bone or the ankle bone. So this patient went on to have a below knee amputation. The really the sort of silver lining to all of it, though, is that prosthetics, the physical therapy we do, and all of the cool, fancy advancements in electronics around prosthetics has helped children and young adults return to really active and wonderful lives, even in the face of an amputation. And so that brings me to kind of the last part of my talk, where I want to talk about what life is like for kids after these types of surgeries, the children and young adults who have these. This is, a picture, a stock image of a girl with an amputation and a prosthesis on her foot, and she's smiling there. And we see that often in our patients. Um, we think a lot about the impact of cancer surgeries, and cancer treatments in patients in this group, and think about how they walk and how they use their arms and their legs. What is their pain like? What's the quality of life that they're able to have? And what's the psychological impact of having a diagnosis like this at a really young age? These patients have checkups for many, many years. They intensely have checkups for at least 5 years after their diagnosis and their surgery. And many are seen for years later to watch for the after effects of chemotherapy. I see them annually for their entire lives to make sure that the mechanical parts of their joint replacements are holding up and aren't wearing out or need to be fixed or replaced. And that can bring some anxiety to all of this, as you can imagine. The constant fear of wondering if your cancer might come back is there, even in these very young patients. But there's a lot of really wonderful things that we know, regardless of the surgery and the type of reconstruction that we do. So whether we do an amputation, whether we do a limb salvage surgery, or do some of those surgeries where there's no reconstruction at all, there's really no difference in how these people function physically. You can imagine that in some areas, an amputee might not be able to do everything that someone with their own limbs might not be able to do. But if the leg functions well, if they have a prosthesis that works well, and they are well supported in that, they do really wonderfully. The vast majority of patients after these surgeries are physically active. They have a wonderful quality of life in all of the groups, when you compare amputation and limb salvage, with no difference in their health-related quality of life. Many are employed to really high percentages. When we look at the two groups, there's no difference in their adjustment to their illness, in the way they think or how smart they are, or whether they're able to go to college or pursue higher education. Um, from a psychological perspective, regardless of which surgery you have, there's no difference in mood. There are no higher rates of depression between the two groups. There's no difference in the prevalence of romantic relationships, which you can imagine that parents of young adults and kids think about, right, their own life and their life and their happiness of their children, and no long-term difference in the development of any psychiatric disorder. So it's really good to know that that these kids can do really well after surgeries and treatments for these types of cancers, and that as long as we are able to do things that help them, give them the best chance at surviving, they have a good chance of having a really nice, long, full life. And so I close with just this last little story. I presume there are some football fans out there. The person I'm going to tell a story about is Mark Herzlich. So the guy who's on the Giants, they're tackling one of our dear own Chicago Bears. So Mark Herzlich, when he was in college, went to Boston College, was there on a football scholarship, as you would imagine who someone playing in the NFL might be. And he was diagnosed with a Ewing sarcoma, so one of these cancers that we talked about. We knew his doctors in Philadelphia knew that he obviously needed to have chemotherapy to treat this. He then had to make a decision about what to do for the tumor itself, to have, and what kind of surgery to have. For him, it was really important for him to be able to try to continue to play football for the rest of his life. It was his passion, and something that really kept him going. And so he had a surgery. He had radiation, which is an option for his type of tumor. And then he had a little reinforcement, and he had a reinforcement surgery of that bone that was radiated. He had some more chemotherapy and clearly recovered and from his cancer and his treatments. He sat out a year or two of his college football career, but finished that and went on to play in the NFL, and actually was on the Giants the year they won the Super Bowl about a decade ago. So a really wonderful story, and a wonderful outcome from a really rare and sometimes complicated cancer to treat. And so, in conclusion, these are really rare things, but something that we at my team and our big team here at the University of Chicago has a lot of expertise in taking care of. We care a lot about these kids and making sure that we are thinking not only about their cancer diagnosis, but certainly for me as the orthopedic surgeon, I'm thinking about the reconstruction, and how we think about functional outcomes and helping people live long, healthy, and active lives. And the one thing we know for sure is that the team approach to these really complicated cases is always the best for us. So with that, I thank you very much for your attention. I'm happy to have been here for you, and I'm happy to answer any questions. Probably stop screen sharing. That's okay.
Thank you so much, Dr. Balach. So a few questions did come into me. The first question here is asking, is there a genetic component to these cancers since they do seem to affect primarily younger populations?
A few of them can. A few of them are associated with um, some mutations of genes that sort of regulate how your body responds to an error or some abnormal tumor growth. So there are some genetic conditions and some gene defects that can predispose kids to having these. But in general, it's they're not something that, say, a parent had and that they pass on, like a parent had the cancer and then they pass that cancer on to a child.
Mhm. And then another question that came through, or what are some early warning signs of this?
Uh, Pain. It's one of the hardest things about making this diagnosis is that it's pain, and young kids, right, have growing pains, and they play and they run and jump, and they hurt, right, they crash the bike and have knee pain, but it's pain that doesn't go away. Kids usually can have fall off their bike or fall off the slide, and in a day they're back to running and jumping to normal. So when they're not able to do that after a couple of days, when pain hangs on for a long period of time, right, then it's a good idea to see the pediatrician or see an orthopedic surgeon to have that checked out. Often, the things that happen commonly are bruises and broken bones, and so those are far more common than any of this. But any check for someone, a young patient who's limping or can't do their normal activities will include an X-ray, and then we can pick these things up pretty easily on an X-ray.
Okay. Someone had asked, I think the question is supposed to be, what is the average age at which this is diagnosed at? Is this primarily in like infants, younger children, teenagers?
We in the pediatric cancer world, there's a word called adolescents and young adults. So these are often kids who are in the 10 to 16, and then it goes a little into the 18, 19, 20-year-old range, but usually it's in this kind of 10 to 14 range. When kids are probably going through a growth spurt, there's some theories that maybe that, right? There's a lot of growth happening, and in moments of lots of growth, is that an opportunity for cells to get a little out of whack and grow in a way they're not supposed to grow. But that, yeah, we see them around in adolescence.
Another question here asks about uh, how often does bone cancer recur, or rate of recurrence once someone is in remission?
It varies a little bit from cancer type to cancer type, and it varies a little bit based on how well patients respond to some of the chemotherapies, but something in the 10-ish% range, 10 to 20, depending on the cancer type. But that is why these patients and cancer patients in general have checkups for a long time. We watch these patients, especially the kids with these bone sarcomas, about every 3 months for the first 2 or 3 years after surgery. And then it gets spread out just a little bit to every, 6 months for a few years thereafter. But we watch them for a very long time to make sure that we see if something's coming back, but hopefully not.
Someone asked, are there disparities among like racial and ethnic or certain populations affected more by this than others, or has that not been found?
No, not clearly. No,
Okay.
it's
Um,
pretty,
oh, go
yeah.
ahead.
These are unfortunately, they will show up in anybody.
Hmm. And then sort of along those same lines, any sort of known, it's t obviously these are happening mostly in kids.
Mhm.
Um, just talking about like causes, if there's not like there's not a known genetic, like a BRCA1 or something that we know.
Right. Yeah, are there risk factors for it? So outside of the few that do have, outside of the few patients who do have, a genetic cause for it, there are not a lot of like predisposing factors for it. So unlike you think about lung cancer, right? We think about smoking associated lung cancers or things like that. That's not the case here. And often that's something I share with patients and their family. Like it's not because they did anything or that someone passed it on to them or anything like that. Because the reason why or the question why always comes up, and unfortunately, we don't know the answer to that. Hopefully, someone far smarter than I am will figure that out, because if we can prevent this before it even starts, it saves a lot of lives.
Right, right. So yeah, it's interesting. So many of the webinars we talk about lifestyle, risk factors, prevention, screening, and this is just one of those cancers where like none of that seems to really apply. Yeah. Um, and then I think you sort of answered this, but um are most patients or many patients able to live a somewhat normal life following their diagnosis and treatment?
For Ewing sarcomas and osteosarcomas, which are the ones that we see most commonly in the adolescent and young adult population, the survival rate is around 70%. So not as high as some of the other cancers that we see and take care of, unfortunately. But that, you're right, that's a majority of those who are diagnosed go on and live happy, healthy lives. And I see lots of patients in my practice who are 10, 15, 20 years out from their diagnosis and original surgeries, which always makes you feel really good.
Hmm. And then someone asked, how rare is this? Just to reiterate, these are very rare
These are
cancers.
very rare. Yeah. So to go back to that statistic from the beginning, within the United States, there are less than 4,000 cases of these bone sarcomas diagnosed every year. The
Mm.
vast majority are in this adolescent younger group. There's a small minority that happen in adults, like over 60, over 65. But of that 4,000, that's probably a quarter or less of them.
Okay. Okay, and those are all the questions that I have here, and I'm just checking our chat box here to make sure I didn't miss anything. If anyone
Those
else has
are
questions,
wonderful questions.
yeah,
Thank you for your attention and your interest, everybody.
our group, they ask really good questions. So I'm just gonna make sure there's nothing else here in the chat box. Okay, I don't see anything else. Dr. Balach, thank you so, so much for being here. We really appreciate you sharing your expertise and taking time with us today.
Oh, it's my pleasure. Thank you so much for having me.